Hi, Dr. Shore and fellow classmates. My name is Kathleen Pelias, and welcome to my presentation. My clinical site is at Chino Islands Urgent Care and Family Practice. It is located at 2103 Pickwick Drive, Camarillo, California, 93010. One of the most memorable and challenging patient encounter during the rotation was that of patient RS. She's a 48-year-old white female patient who presented to the clinic alone. She is alert, oriented to time, place, and person, and she seemed to be a reliable historian. Her chief complaint is, I've had abnormal and irregular vaginal bleeding for the past 3 months with an agonizing pelvic pain. History of present illness, abnormal and irregular vaginal bleeding with agonizing pelvic pain over the past 3 months. However, the pain has become unbearable over the past month. She's concerned as she reported this as something she never experienced before, and it has worried her. The patient also stated that this heavy, irregular, and abnormal bleeding occurred outside of her relatively regular menstrual cycle and was heavier than the usual, sometimes lasting for up to 13 days. The pain she experienced in her pelvic region increased during sexual intercourse, and she experienced a constant dull ache in her pelvic region. The patient also explicitly denied any history of sexual transmitted infections, with her last pap smear being around 2 years ago, which was normal. The pelvic pain resulted in a rapid decrease in appetite and sleep disturbances. Another significant piece of information presented by the patient was that the pain and bleeding hindered her from performing her daily usual activities, including her work and responsibilities. She has a remarkable past medical history pertinent to her condition and relevant manifestations. These are history of hypertension and hyperlipidemia. She denied any recent changes in her contraceptive use or menstrual cycles, denies a history of sexually transmitted infections, and established that she had no diagnosis of any gynecological conditions that she is aware of. She's also compliant with her medications for hyperlipidemia and hypertension. And she also denied a history of diabetes, asthma, and other medical illnesses that could have progressed and presented in the form of the symptoms she displayed. She had no reported allergies or surgeries. The only medication that she is taking is lisinopril, 20 milligrams once a day. Her family history, she reported a family history of breast cancer, with her mother being diagnosed at the age of 50. Her father succumbed to prostate cancer at age 60. She has 2 sisters, both of whom are healthy with no history of gynecological or breast-related issues, with her maternal aunt having a hysterectomy in her late 40s. This was prompted by uterine fibroids, and her paternal grandfather have colon cancer history, diagnosed at 80 years of age. This patient stated that she was to have a hysterectomy 2 years due to endometriosis after painful menstrual cycles and experiencing similar degrees of pelvic pain, but never consented to any surgical procedure and has been using hormone replacement therapy since then. She denies any genetic predispositions to STIs, with all females in her family receiving reproductive health education during their teenage years and regularly attending gynecological appointments every year. Social history, she is currently working as a marketing director at a local finance firm dealing with fintech. She reported that she is married with two teenage children, 15 and 19, and stated that she resided in a stable home environment with the two children. She is also a social drinker with a history of smoking and reported that she consumed at least half a packet a day for the past 20 years. Furthermore, this patient argued that she had no known drug allergies or habitual drug use or surgeries. The patient established that the recent pelvic pains that she experienced hindered her from delivering professionally and that the pain increased with her stress level. She reported that her home and work environments were free from exposure to toxins, pollutants, or hazardous chemicals that may have put her at risk. Her review of system is unremarkable except for the constitutional. She reports feeling fatigued, but she did not experience any recent weight loss. GI, she acknowledges persistent abdominal discomfort, nausea, vomiting, and diarrhea. No changes in bowel habits were reported, and patient reports occasional constipation. Also with the genitourinary, patient reports experiencing abnormal and irregular vaginal bleeding for the past 3 months, accompanied by the pelvic pain. No dysuria or hematuria is noted. She also has reported a new onset rash on her lower extremities, which started 4 weeks ago. No, it wasn't itchy, probably because of the climate and weather. Psychiatric, she reports feeling depressed and anxious due to the recent onset of her symptoms, but she denies any past psychiatric illnesses. And lastly, for the endocrine system, she denies any recent symptoms of hyperthyroidism or hypothyroidism. Objective data, her vital signs are normal: BP 120/80, heart rate 80, RR or respiratory 16, temperature is 98.6, her weight is 160, height is 70 inches, her BMI is 23 kilograms m squared, indicating that she is in a normal body mass index. For objective data, the patient is alert, oriented to person, place, and time. She appears uncomfortable due to pelvic pain, but is able to communicate effectively. For her GI, she reports nausea and decreased appetite, but everything is unremarkable on the GA system. Psychiatric, again, she is appearing anxious and worried due to her symptoms. Integumentary, skin is intact without lesions or bruising, but she reported, just a rash, and I was able to see just the healing rashes on her bilateral lower extremities. GU, the pelvic exam reveals a normal-sized uterus with no obvious lesions. Cervical swabs were taken for possible infectious etiology of abnormal bleeding. Transvaginal ultrasound was ordered to further evaluate the uterus. Hematologic or lymphatic system, blood work was ordered for possible anemia or other hematologic disorders. We ordered CBC, CMP, anemia panel, CRP, HbA1c. What else did we order? T3, T4, TSH, and then the ferritin levels too. We checked that, and The results are still pending. Assessment. I have 4 differential diagnoses based on the patient's chief complaint, primary medical history, physical examination. Number 1, uterine fibroids. The first differential diagnosis for that patient, according to Giuliani et al. 2020, uterine fibroids are main cancerous growths within the female reproductive system that develop in the muscular world. The condition is also known as leiomyomas and is common gynecological illnesses that affects women during the prime of their reproductive years. The primary issue with this condition is that it affects its diagnosis is its commonality in symptomatic manifestations in some women, with the majority of the individuals having uterine fibroids experiencing no symptoms other than pelvic pressure and prolonged menstrual bleeding. The chief symptoms of this condition that resulted in its consideration as one of the key differential diagnoses for this patient, including constipation, painful intercourse, and abnormal and irregular uterine bleeding. According to Giuliani et al. 2020, established that abnormal uterine bleeding among patients with uterine fibroids manifests as menorrhagia or metrorrhagia. My second differential is adenomyosis. Adenomyosis was the second differential due to the commonality of the symptoms presented by the patient and the signs of the disease. According to Chaperon et al. 2020, adenomyosis is a common and prevalent illness characterized by the tissues within the inner lining of the uterus, the endometrium, growing abnormally into the muscular wall of the uterus, or myometrium. Previous research has established that this condition is predominant in women with a history of multiple pregnancies and commonly manifests in their 30s to 50s. Chaperon et al. 2020. Moreover, understanding the exact cause of adenomyosis remains a critical headache for healthcare practitioners and medical researchers with this condition believed to be associated with hormonal imbalances and inflammation. The rationale for considering adenomyosis as the primary differential diagnosis for this patient is the chronic pelvic pain, heavy menstrual bleeding, painful intercourse, and the enlargement of the uterus, reported as an extended bowl. However, the absence of menstrual pain and regularity of the cycles was the primary factor considered when ruling out this illness. My third differential is endometrial hyperplasia. This patient's symptoms and the findings of the physical examination may be demonstrative of endometrial hyperplasia. Ring et al. 2022 defined this as a condition that manifests in the form of excessive proliferation of the endometrial lining of the uterus and that has an association with the opposed estrogen exposure, resulting to imbalances between progesterone levels and estrogen. Endometrial hyperplasia can occur at any age within a woman's life cycle. However, this condition is common in postmenopausal and perimenopausal women, with its signs and symptoms varying significantly depending on the hyperplasia type and the suffering of the illness. She reported that she had abnormal uterine bleeding and pelvic pain, all of which are primary signs and symptoms of endometrial hyperplasia. However, the patient had a slightly distended abdomen, which is absent among women with endometrial hyperplasia. Endometrial cancer is the final differential diagnosis for this patient. Endometrial cancer, a common gynecological cancer in women that develops from abnormal cell growth within endometrium. According to Brooks et al. 2019, the diagnosis of endometrial cancer is common in postmenopausal women, but might not exclusively exempt premenopausal or perimenopausal women. The primary complaints of this patient of abnormal uterine bleeding and pelvic pain are consistent with the signs of this cancer. However, this diagnosis was ruled out due to the absence of weight loss, which is common in cases of endometrial cancer. What is my diagnosis? I settled for a tentative diagnosis of uterine fibroids. My diagnostic plan, of course, we ordered blood work. We also did pelvic exam. Developing and implementing an appropriate diagnostic plan is the first step to the successful treatment of uterine fibroids. Lin et al. 2022. The first step in the diagnosis of RS involved gathering objective data, which we did, and performing a comprehensive physical examination. However, this step did not yield sufficient data to make a conclusive diagnosis and to develop a treatment plan. Consequently, imaging tests such as transvaginal ultrasounds and MRIs was also ordered. The former test involves the use of sound waves to create images of pelvic area, making it non-invasive and essential in detecting the presence of fibroids, their size and location, according to Adebamuwo et al. 2023. MRI tests are more advanced and provide comprehensive and detailed images of the internal structures of the uterus, making them preferable to healthcare providers when assessing gynecological conditions. Lin et al. 2022. Other tests that were ordered for this patient included pap smear tests and, again, blood tests to explore the hormonal levels and rule out other illnesses such as anemia. My treatment plan, if the patient ended up with my primary diagnosis, the management of uterine fibroids typically involves a combination of pharmacological and non-pharmacological approaches intended to relieve symptoms and prevent further growth of the fibroids. Gilani et al. 2020. Most healthcare professionals use existing evidence that supports the use of medical therapy as the first line of treatment for fibroids. 3.75 milligrams of leuprolide was injected to the patient subcutaneously to assist in suppressing the production of estrogen and progesterone. This medication is also commonly used to decrease the size of the fibroids and relieve symptoms such as pelvic pain and heavy irregular vaginal bleeding. Yamada et al. 2019. Tranexamic acid was also prescribed for the patient, 1.5 grams, which was to be taken orally 3 times a day during bleeding to assist her in decreasing blood loss. Additionally, the patient was to report back to the clinic for many mainly invasive procedures, such as uterine artery embolization aimed at destroying fibroids while preserving the uterus after obtaining MRI results. Another procedure that was considered, but we did not perform it. We went ahead and referred her to a gynecologist. Myomectomy is a surgical procedure aimed at preserving fertility too. Follow up with patient in 3 days to discuss the diagnostic results and treatment options. Patient education. Patient education for this patient was critical in assisting her in managing her symptoms and improving overall health and well-being. Also, we added for her pain just ibuprofen, 800 milligrams as needed, preferably every 8 hours, 6 to 8 hours. So we go back to the patient education. According to Gilani et al. 2020, uterine fibroids are notorious for decreasing the quality of life of patients. Therefore, patients must receive information and knowledge that will help them to manage this condition and associated symptoms. First step is involving a detailed discussion of the different treatment options available and the level of effectiveness in managing her condition and symptoms. The patient was informed while she took the prescribed medications and the justification for not engaging in invasive surgical procedure during this initial visit. Furthermore, patient education process also involved dispelling myths and misconceptions regarding uterine fibroids, as the patient was concerned that her condition would worsen and result in uterine cancer. She was educated on how to manage the conditions to avoid further progression of symptoms and the inevitable nature of surgical procedures depending on the size and location of the fibroids. Holistic approach and caring science. Collaboration is a critical concept in the current healthcare industry due to its instrumental role in facilitating the attainment of better outcomes. The changing healthcare provision landscape dictates that practitioners collaborate with patients and their families to improve the quality of healthcare services. Schott et al. 2020. RS condition warranted collaboration with her that would involve her in all decision-making processes and incorporate her input in developing an appropriate care plan, discussing the underlying causes of her symptoms, explaining the diagnostic and treatment approaches, providing education about her condition and the most feasible approaches for management, and preparing her for potential outcomes. Involving patient's family members would also be an appropriate thing to do in providing her with the emotional support they need and insights into the family history of this patient. However, the patient presented to the clinic alone, eliminating any possibility of collaborating with other family members. Another important aspect of collaboration that played a critical role in guaranteeing the quality of service given to this patient was a good mentor, health care provider. We would have collaborated with other experts, such as the gynecologist, from general to specialized clinics, including radiology, gynecology, oncology, to ensure that the approach to this patient was appropriate and coordinated. All these aspects, collaboration could have pivotal in achieving better healthcare outcomes. Thank you so much for listening.